Vicky, for inviting me. It's a pleasure for me to be here today. And well, if you can advance the slides, please. Thank you. We will present an approach to assess cardiovascular risk, mainly in primary healthcare settings, for decide who patients will need a different approach. As you can see in this slide, in the region of Americas, the decreasing trend in premature mortality due to cardiovascular disease that was observed in the last 3 decades has stopped. In some countries, it has even been reversed and cardiovascular mortality is increasing. Next slide, please. And if we look at the main risk factors, hypertension leads the attributable risk fraction for stroke. Next slide. It's in the second place for myocardial infarction. Next. And it's in the first place for cardiovascular mortality. Well, next slide. And we have the tools for to fight against hypertension. Firstly, the healthy lifestyle recommendation, as you know. Next slide. And secondly, and most importantly, the pharmacologic therapy that not only reduces the blood pressure, all pharmacologic groups have similar effect in monotherapy, but also, next slide, these drugs reduces the major cardiovascular events and even total mortality. Next. However, this is the situation in our region when even high-income countries like the United States have major gaps in coverage, treatment, and control. Next, please. This is the context that supports HEARTS in the Americas and its guiding principle. As you can see in these slides, our guiding principles are first, country ownership. HEARTS is led by the Ministry of Health with the participation of other stakeholders and PAHO's technical cooperation. HEARTS is simple and practical. The initiative provides pragmatic, cost-effective, and feasible solution to primary health care. HEARTS is also an evidence-based initiative, promotes the adoption of best practices in preventing and controlling cardiovascular disease and improving health services organization. HEARTS is accountability. It is a data-driven initiative. Continuous learning cycles, peer-led teaching, dissemination of effective innovation and lessons learned during implementation. It's a long-term strategy integrating elements into the exciting healthcare system, and HEARTS increase the primary healthcare facility, recruiting more primary healthcare facility and increasing the speed of model institutionalization. Next, please. Treatment and control of hypertension is the top priority, but is that enough? This is the question. What is the importance of knowing and treating global cardiovascular disease risk? Next, please. And what is the global cardiovascular risk? Cardiovascular risk is composed of the combination of multiple risk factors, many of which have common pathophysiological pathways and interact with each other to increase their deleterious effect as well. Next slide, please. And in 2021, the WHO released its guideline for the pharmacological treatment of hypertension in adults. And what about cardiovascular risk in this guideline? Firstly, WHO recommends initiation of pharmacological antihypertensive treatment of individuals with a confirmed diagnosis of hypertension and systolic blood pressure over to 1400 or diastolic blood pressure over 90. That is a strong recommendation. Regardless CVD risk level, hypertension should be treated in all cases and without delay. But regarding the cardiovascular risk perspective, the World Health Organization recommends pharmacological antihypertensive treatment of individuals with existing cardiovascular disease and systolic blood pressure of or between 1300 to 139. That means set a lower threshold for initiate pharmacologic therapy. And also WHO takes the CVD risk approach to suggest pharmacological treatment of individuals without cardiovascular disease, but with high cardiovascular risk, diabetes, mellitus, chronic kidney disease, and the same values of blood pressure. The most importantly is the implementation remarks. Treatment should start no later than 4 weeks after diagnosis. If blood pressure is over 160/90 or an organ damage is present, start without delay. Next, please. In this slide, you can see how the presence of diabetes and its control as well impact in cardiovascular disease mortality depending on the blood pressure level. Next slide. And we observe the same relationship between risk level and cardiovascular events avoided when we consider the global CVD risk level. Next, please. But beyond seeking stricter blood pressure goals according to cardiovascular risk levels, there are other concomitant treatments to consider. For example, aspirin. And in the secondary prevention scenario, that means among patients with established cardiovascular disease, the benefit of aspirin is consistent for all events and far outweighs the bleeding risk. Next, please. But the question is, what is the impact of aspirin use in primary prevention? And in this scenario, the net clinical benefit is scarce because aspirin in primary prevention does not reduce total mortality nor cardiovascular mortality. And aspirin in primary prevention does not reduce stroke as well, and increases the risk of major extracranial bleeding, mainly gastrointestinal bleeding. Next, please. Regarding the other relevant drug, the statins, the benefits are huge among patients in secondary prevention, but also these benefits are consistent in primary prevention too. And the statins have excellent safety profile and have also high impact over cardiovascular events and mortality. Next slide. And as with blood pressure, the absolute benefit will be greater in patients at high cardiovascular risk treated with statins. Next, please. So, to resume, why should we estimate cardiovascular disease risk? First, to establish different treatment regimens. For example, who should be treated with aspirin or statins. Second, to establish the need of more intensive blood pressure threshold and targets. 3, to establish different follow-up interval for control. 4th, to assess the need for consultation with specialists. And finally, to improve healthcare with efficient use of resources and impact the reduction of cardiovascular disease and premature death. Next slide, please. And as you can see, the treatment impact and the efficiency in resource utilization will be higher among high CVD risk patients. Next. There are a lot of CVD risk scored. But what is the best CVD risk score? All of these include a very strong variable in the model behind the calculators. And unfortunately, we cannot modify it. This is the age. In the figure, you can see the area under curve for the Framingham score, 0.77. But if we develop a CVD risk model using only one variable, using only the age, we will obtain an area under curve of 0.70. This is pretty similar. Next, please. So, therefore, the calculator to be used is not the most important thing. The main objective is to assess cardiovascular risk. In a world with many cardiovascular disease risk models and calculators, more than 50% of healthcare providers in the region of America do not assess cardiovascular risk or do so in less than 25% of patients, as you can see in the slide. Next slide, please. And this is related to the treatment because even among patients with previous stroke or myocardial infarction, this data is from a pure study, only 50% receive full treatment in high-income countries like the United States. Next, please. So we have developed a implementation tool, a practical app that is the HEARTS app, to assess cardiovascular risk, mainly in primary healthcare settings. Next, please. This app recommends and use a pragmatic approach to assess cardiovascular risk. First, there is a question. Does the patient have a history of cardiovascular disease? That means coronary heart disease, cerebrovascular disease, or peripheral vascular disease? Next, please. If the answer is yes, this is a high-risk hypertensive patient. And the use of CVD risk model should be avoided. If the answer is no, so the app shows another question. Does the patient have chronic kidney disease? Again, next please. If the answer is yes, we have a high-risk hypertensive. If answer is no, the app shows us the third question. Does the patient have diabetes mellitus? If the answer is yes, this is a high-risk hypertensive. And in case the answer was no, so we must use the calculator. And this calculator that the HEARTS app includes is based on the WHO charts that was published in Lancet in 2019. And this CVD risk model fit the tables according the region of work. Next slide, please. And this is our main implementation tool. This is the HEARTS clinical pathway that we use to implement the HEARTS in the Americas strategy, the HEARTS in the Americas initiative in 24 countries in the region. Next, please. And this is the ABC to CVD risk management in primary healthcare, because in the step A, we are recommending measure blood pressure in all adults and adult visits. Next, please. And next. And the use of a standardized protocol to measure blood pressure and recommending the clinically validated blood pressure measurement device. In the step B, we recommend assess cardiovascular risk in all patients using our HEARTS app. And in the step C, next please, and according to guideline from WHO organization, we recommend start treatment immediately after confirming hypertension. Next, please. And we recommend different thresholds for initiating pharmacologic therapy according cardiovascular risk level. Again, we introduce this pragmatic approach to CVD risk evaluation, and we set different targets for blood pressure control according cardiovascular risk. Next, please. And also we classify high-risk hypertensive into two groups according the presence or not of cardiovascular disease. For recommend aspirin. Next, please. and different doses of statins. Next. And finally, we have the standardized treatment protocol for hypertension treatment. Next, please. We integrate all recommendations, the healthy lifestyle counseling and the pharmacologic recommendation for hypertension treatment, encouraging the use of fixed dose combination. That means at least two drugs in a single pill combination for treating hypertension. Next, please. We also recommend only four steps to medication titration and others recommendations related to WHO guideline and the key drivers for hypertension control. Next slide, please. Next. And in the bottom of this HEARTS clinical pathway, we also include the frequency of follow-up according cardiovascular risk, the supply of medicines, and also the vaccinations. Next, please. And other recommendations such as take all medication at the same time every day, or assess treatment adherence at each visit. Next, please. And next. And next. So the hypertension clinical pathway is the main tool for HEARTS implementation, promoting a comprehensive approach of CVD risk management in primary healthcare. Next, please. So to conclude, hypertension treatment is the top priority, but this treatment is best tailored according to the level of cardiovascular disease risk, as recommended by the HEARTS clinical pathway. Next. And the HEARTS clinical pathway allows a pragmatic approach to CVD risk, strengthening the secondary prevention through the appropriate indication of statins and aspirin. Next, please.